Hey, it's Owen Robinson. This is the Rejuvenate podcast, and today we're going to be talking about perimenopause, menopause, hormone replacement therapy. Is it good? The different types, the type that your normal doctor going to recommend you, is that worth getting? All of that kind of stuff. And because I'm not an expert in this, I'm thrilled to announce that we are once again joined by Dr. Miriam who is a doctor of both normal medicine and integrative and functional medicine, with a bunch of other specialties as well. She's on the board that certifies of IFN, Institute of Functional Nutrition. She is Institute of Functional Medicine, sorry. She is a specialist in longevity and skin health, with a deep set of experience as well, helping clients to optimize in all kinds of domains, including hormones. And the reason why I wanted Dr. Miriam to talk about this today, well, funnily enough, I just was speaking to a client the other day, Dr. Miriam, who is 65 years old, various different health challenges, including bone loss and, osteoporosis. And I said, has anyone ever offered you any kind of hormone replacement therapy? Have you ever tried progesterone, bioidentical progesterone, anything like that? She said, no, nothing. Not even a conventional medical doctor offering like the mainstream estrogen medication. I was like, it just blows me away. So that's like really clear cut to me, and we'll get your take in a sec when I let you talk about like if that if you agree with that maybe any woman by the age of 65 should be considering some kind of hormone replacement. But we'll also be talking about more niche examples, like what if you're only 42, but you're starting to not feel as good, or maybe even, hey, in some cases younger than that. So we'll do a different episode about males and their hormone declining and andropause in an upcoming future episode. But in this episode, we're focusing more on women. But if you're a man, don't tune out, because unless you live completely isolated from women, what you learn here, it would be a really good idea to share this with the women in your life, especially as they get older. They will be much happier, much healthier, and probably much more enjoyable to be around once you help them optimize their hormones. So this is really a great education for everyone. And with that long introduction out of the way, thank you for joining us, Dr. Miriam, and welcome back to the show.
For having me, Owen. And no, I think it is a very important topic. And as you said, even though um, you may not be female yourself, you likely live or know people that would be affected by this area. And it is a huge issue, but I would say a very nuanced one. And we'll get into this, but as you mentioned, like replacing estrogen, um, yeah, I agree. Like that would be something you should think about in I'd say a woman between the ages of like 40 and 70, as like could it be hormone deficiency. But I think there are other examples where you really have to just make sure it's appropriate, but then also just the wide range of things that hormones affect. You can actually do a lot of good, just thinking about holistically what hormones do overall.
Yes. All right. Well, let's break it down, Dr. Miriam. Let's start, if you don't mind, as a structure of the episode. Let's start with talking about what perimenopause and menopause is and what hormones are involved. Then let's talk about what happens if you don't do anything about it, if you don't replace any of those hormones, or what's likely to happen. Then we'll talk about the conventional medical approach, if they do anything, which is not guaranteed, as we said. And of course, you know this because you work in the conventional medical sphere. You see NHS patients as well as privately. And then lastly, we'll go into maybe the bulk of the episode, which is the right way of doing things. Is
Yeah,
that
sounds
okay?
great.
Okay. So let's start to go. So the first one, what is perimenopause? What is menopause? What hormones are involved, and what does it do to a woman to go through perimenopause and menopause?
Yes, so actually, in this case, I think it makes sense to start with menopause, because officially the diagnosis of menopause is that you have been um, menstrual period free for a period of 2 years. And then when we kind of look back on that, usually there's a period of several years where you're not period free. You're either missing periods, or have had more frequent periods. basically a lot of signs that your hormone levels are dropping, but also in some cases fluctuating, particularly kind of towards the beginning. But generally, we associate that period where it's not quite, it hasn't really reached that menopause stage as perimenopause. That's sort of the official like conventional medical definition. But I would argue to say that the perimenopause still overall represents a period of predominantly hormone decline, in some cases a bit of fluctuation, and we start to associate many of the symptoms of hormone decline or fluctuation is often then labeled as the perimenopause. So that can include things like changes in mood swings, lower energy, um, and the kind of things that we tend to associate with with menopause and sort of aging around that time period.
Hmm. Okay, that makes sense. And so, what would be the top three signs of menopause or even perimenopause starting that you'd be looking for?
It's a tough question because I would say there's actually so
Or top
many.
five, top five, top 10, whatever you want to give.
I mean, traditionally, we always think of hot flushes as sort of the predominant like menopause sign. Um, of course, there can be other reasons for hot flushes, but that was, I'd say, would be the number
In
one.
fact,
Yeah.
let's dig into that one then. Sorry. What causes hot flushes in the case of menopause? What's actually going on hormonal level? I think maybe a lot of women, even who've had them, don't really know this, so it should be of interest to most people.
So what actually causes the hot flush is a rise in adrenaline levels. Um, and but that is usually caused by that drop in estrogen. And so, but the reason I mentioned the adrenaline is that you can have hot flushes for, where you feel hot, sweaty. You might actually have those physical signs that you are actually sweating more. And that doesn't necessarily mean that it's because your estrogen levels are low. It likely means that they are lowering and there is some fluctuation, but you can also have um, hot flushes with some adrenal thyroid issues. And that's where you have to be careful that you're not just plopped on estrogen without investigation just because you have hot flushes. Does that make sense? Yeah. Yeah.
Absolutely. So, what if it's mainly is it mainly adrenaline or exclusively adrenaline that causes it?
I mean, my understanding is it is pretty much that link between the cortisol, estrogen, and then adrenaline, but it is specifically the adrenaline rise that causes the hot flush.
I'm just thinking, is it basically the same as a panic attack then, in the sense of like the physiology of it?
You know, pretty much. And so,
Interesting.
which you don't think about it, but yes, I would just say that that drop in estrogen is likely to fuel that rise in adrenaline more frequently at certain points of the day, and so you do kind of indirectly link it to the drop in estrogen. But it's not exclusive. I guess my point I'm trying to make.
But the actual feeling is adrenaline. That's interesting. Okay. And then, yeah, let's get into what happens to you over time then if you do nothing about it, which is unfortunately, as you say, like the default.
And this sort of ties in, sorry, to the other symptoms that I tend to associate with menopause. But the one is memory loss and brain fog. Um, and another would be um, um, mood fluctuations. I would say both anxiety, but also low mood and irritability. Um, those would probably be the top three. I would say if you want to expand a bit more, they might not be so much noticeable signs, but for example, things like bone loss, reduced muscle mass. Uh, you may not wouldn't notice them right off the bat, but those are something we could attribute to that perimenopause menopause stage as well.
Yep. Okay. Um, and so I think there's this kind of, tell me if it's right or not, but this idea that menopause is something that women go through, and during it they may be hot flushing and upset and all the rest of it, but then they've kind of gone through it and then they're fine again. Like, is that accurate from your perspective?
Yes and no. So I would say that um, many of the what we would call these vasomotor symptoms, so those are the hot flushes, things, because that's tied to more the drop in estrogen setting off the adrenaline, that does tend to pass. Um, However, I would say that kind of the symptoms that are more predominantly because of the low estrogen, um, like brain fog, lower energy, that doesn't really seem to pass. And so I would say without intervention, that kind of memory loss I would expect to get worse without replacement.
Okay, so brain fog, memory loss, low energy, bone density going down. Those are all things that just carry on. They don't like get better again as the menopause is over and a woman becomes postmenopausal.
No, not without added intervention. And you specifically mentioned the case of bone loss, which is a huge problem. And I was reading a report the other day about how they estimate that half of women, in men who are menopausal, do have some form of osteopenia, osteoporosis. Just a lot of them just never check. But I would say that I mean, so probably there's some other causes. There are other causes as well, because some of those 50% are likely on estrogen replacement. But it is something that will generally get worse unless you're replacing hormones, but then also, you're taking care of other lifestyle factors, maintaining muscle mass and strength. So it is also, multifactorial.
Yeah, okay. And you've talked a lot about estrogen so far, which is the mainstream perspective. The thing that I tend to focus on, I'm not saying this is the right thing, it's just where my mind goes, is progesterone more, and specifically its impact on reducing stress and reducing inflammation for women. And then you have this, maybe primary hormonal tool to oppose cortisol and oppose stress. And then suddenly the levels go to almost nothing. Like, what impact does that have on a person?
Huge impact. And I would say progesterone, specifically, bioidentical oral, progesterone has a huge impact on nervous system health, sleep. And one of the things I see very commonly in practice is, let's say, someone has had their estrogen replaced, but they're I would say that in the conventional medical view, they don't really look at the holistic impacts of progesterone, and they sort of discount that it does anything. Conventional medicine just sees progesterone as something that protects the uterine lining against the effects of estrogen. Discounting
Yeah,
that
amazing.
every organ in your body pretty much has progesterone receptors. So obviously, it is a systemic hormone. And maybe this is going a bit too much into specifics, but what I see is a lot of women who are on contraceptive coils, so which are synthetic, typically tend to be things like Mirena, which has a synthetic progestin. Um, that does help protect the uterine lining, but it's obviously not going to have any of the systemic effects, and that will then just drive your own progesterone production to zero. And so there is a role for still replacing it, even if somebody is on a coil.
If you're eating clean, exercising, and your belly fat just won't shift, listen up. The number one cause for this happening is insulin resistance. It's the number one hormonal imbalance, which explains why people in their 30s, 40s, and beyond just can't lose weight. I'm Owen Robinson, and together with Dr Miriam, we created the Hormetics Weight Optimization Formula. Insulin is a key part of that. More and more people every year are being diagnosed with insulin resistance. It is the number one reason why people struggle to lose weight so much. And that's why we created the Insulin Balance Formula. It's our most popular formula. It contains precisely chosen quantities of berberine, fenugreek, zinc, and folate, which are all clinically studied ingredients shown to lower insulin, kill cravings, and turn your body from a fat storer to a fat burner. Go to advancedhealthgenetics.com/insulin, order now, and you'll be invited to join our clinical study the moment you check out at no extra cost, so you can track exactly how well and how effectively it works for you. Use code REJUVENATE as well to get 20% off. End the blood sugar roller coaster. Go to advancedhealthgenetics.com/insulin and use code REJUVENATE for 20% off now. Kind of like with anabolic steroids, where it's not actually testosterone, but it still drives your testosterone production down to almost nothing in men. It's kind of like a similar thing because it's a fake version. Okay, so we covered briefly what happens to you if you don't do any replacement. I think you're kind of segue into the next section, which I agree. Let's get into that. So let's talk about the conventional medical approach. Let's say you go to the doctor and they don't just give you nothing or an antidepressant, as we were talking about before we started speaking. In fact, let's briefly talk about that actually before we get into it. Well, let's just address it. So say I'm a woman, I'm 55, I'm going through the menopause, or I've gone through the menopause, I'm going to a doctor, I'm suffering in these various ways. Let's say I have all the symptoms we just talked about. What are they likely to offer me?
Say, like 20 years ago, because you would see these cases, women who almost were kind of on the state of like an emotional breakdown would go to their GP and they're like, I can't find my keys, I get lost in the parking lot, I'm anxious when I never used to be. Um, many things, and the first response was usually just to go into the mood aspect and offer an antidepressant, and that was actually um, in the guidelines for always consider what a woman is going through and consider that it could be depression, that they're in overwhelm. But then I would say even the conventional medics really started to push that, we really do need to be looking at hormones, and this is a period where hormones dramatically decline, and that decline in levels is what is really behind most of the symptoms. But I would say that the conventional medical community still focused predominantly on estrogen. And you said,
And sorry, when was that shift? Because there might be people watching who they're old enough that they never had that, right? And so maybe some of them did. When did that happen in
I
your
would say
experience?
in, even the last 10 years, I mean, my approach is probably more UK centric, but there was a lot of media about actually hormone replacement and how it helped, I'd say higher profile women get out of this sort of state. So there was much more of a conversation about hormone replacement therapy. And then, yeah.
I'm just thinking this might explain the client I saw who's 65. Maybe she went through it 15 years ago, right? And it just wasn't a trend yet, just hypothetically.
Wasn't a trend. I would also say that, you know, like in the UK, a GP or family medicine doctor is supposed to be trained in all of these areas, but there was I mean, I've had experiences where like certain male GPs would just they wouldn't really want to see any perimenopausal, menopausal females, and they would just sort of shift them to the female doctors in the practice. And so it could have been the case as well that then maybe doing that and then not having the experience, they might then have come across like a female patient like the one you mentioned, where it just they don't see it enough for it to come across as something that might be explained by a decline in hormones. Um, yeah.
Okay. So anyway, all right. So we focused enough on the thing that blew my mind is them offering nothing. But as you said, what they do offer is problematic. So especially the estrogen only approach, right? So could you explain that a little bit more?
Yes, I mean, I would say it's obviously not problematic for everyone, but the approach is first of all see if there's no direct contraindications to estrogen, and so a direct contraindication would be breast cancer in the last 5 years, uh, blood clot, like recent blood clots. Um, typically, typically, if you've had a strong family history of breast cancer, I think you still have to be like have had a family history of like BRCA1, or if you yourself have a BRCA1 gene, then you also wouldn't be able to have estrogen. Um, and yeah, so there's some really strict criteria of when women cannot have estrogen replacement. But once you sort of ticked off that you don't have those, pretty like strict criteria, um, then generally kind of estrogen was seen for women as being the hormone that would solve all of those issues. And I'm not saying it doesn't. Like I would say predominantly for things like bone loss in women, we do think estrogen plays the biggest role. So does testosterone, but maybe not to the same degree. And for things like brain fog, memory loss, we also see estrogen playing a significant role there. So it is, I would say, better than nothing. Certainly, in most cases, better than an antidepressant. Um, but yeah, but that was kind of what was offered. And just to kind of finish the thought there, but they were viewed as, okay, the progesterone in someone who has a uterus needs to be added to balance out the estrogen. So you would have to prescribe the progesterone at the same time, unless the person had a coil in or they had had a hysterectomy.
Okay. And so this perspective on estrogen, I want to, bring this up because we've had Dr. Michael Platt on. We've talked a few times about Ray P. Both of these, I think, were quite early pioneers, along with Dr. John Lee in the area of progesterone research. I don't want to speak for them, but the general impression I get from them is that they viewed estrogen as quite a dangerous substance that you don't want to have in excess, and that it's very important to have the level of progesterone that is sufficient to balance out the negative effects of estrogen. And then I don't want to put words in those particular gentlemen's mouths, but I've seen certain other people who are followers of theirs who make even stronger blanket statements like, there is no benefit to estrogen, or, but a famous influencer who I won't name because I'm not trying to start internet beefs, but like, and this is a woman, estrogen is not the female hormone, progesterone is, and estrogen is useless, and all this kind of stuff. So I know you're kind of familiar with that world, which is the only reason I'm asking you about it. And a lot of them are, you know, I suppose with the exception of Dr. Platt, who was a doctor who was seeing patients for a long time, a lot of the rest of them weren't. So, what's your kind of what would be your reply if one of them were here now and saying those kind of things?
I would say, I mean, I do agree that compared to the conventional medical view, we have to take it in the holistic view is to look at all of the hormones and be replacing all of the ones that are appropriate to replace. Um, I do, I think that there is enough research to support that, things like cognitive decline, bone loss, can be directly linked to that drop in estrogen. And I would say from a clinical perspective, I mean, I have seen estrogen over replaced by other practitioners, and I see that a lot. I think, predominantly because of that model where it tends to be the hormone that's replaced, and there isn't really that culture of then checking your levels very often in the conventional medical world. And I would say even in the private medical world where people are kind of saying that they are holistic, but actually they're using more or less the guidelines of the conventional. So I've had client referrals where um, they were told by a private medical doctor to just keep increasing the estrogen until they felt symptomatically better, even to the point where they were actually being told to take multiple forms of estradiol, spray, patch, cream, and they had no idea what their levels were. They were just told, well, once you start feeling better symptomatically, stay at that dose, which I was, I mean, frankly, horrified to hear because, there is a, when I say danger in estrogen, I would say that there is we know that there are estrogen receptors, for example, on certain cancers and things, and you don't want to be fueling that should you have, some growths, even if it's on a cellular level. So you do have to be very conscious. But I would argue that when a lot of negative press came into kind of the public sphere from the Women's Health Study and the Women's Health Initiative about how estrogen causes breast cancer, we've had many re-reviews of that study, and the predominant viewpoint from there was actually that it was the synthetic estrogen, the synthetic progestin that we think was the culprit, and they weren't seeing those increases in women who were replaced with a bioidentical. Yeah.
Could you explain the difference between synthetic and bioidentical, and then which of those does a medical doctor give? Is it a combination? Do they only give one or the other?
So bioidentical just means identical to what your body would be producing. I think that the confusing thing is it technically can be synthetically produced, but you can still have that estradiol component be identical to what your body would be producing. So, but there are actual forms of estradiol that were synthetically altered to not be, um, to not be identical to what your body's producing. And those we think are kind of on the lines of something like a xenoestrogen that would be, um, actually quite toxic to the body.
So Premarin is famous, right? It's made out of horse urine, and I don't. Is that still used in medicine?
I mean, in our current guidelines, no, I think it still might be used in parts of the world, but they've altered that estrogen molecule so that it's conjugated, so it is biochemically altered, and so it does change how the body views it and how it can react with the estrogen receptors.
Now, the conspiracy theorists would say, if, to answer the question, why not just use bioidentical hormones if that's what your body's used to and it makes itself, because they're not patentable, right? And with the altered forms, they're patentable and therefore you can make more or any money out of them. Um, I assume that's not what they taught you at medical school. Why did they teach you? What reason did they give as to why they give non-bioidentical hormones instead of bioidentical to people?
Actually, it's a good question because, I would say that where I was taught to use hormones, unfortunately, it was very much driven by the cost, and that was just, from an
Okay,
NHS
cheaper.
perspective. Um, yeah, definitely cheaper, and with the NHS, it's for them, it's like even if it's cents cheaper, that still saves them money if it's collectively across the entire country. Um, I would say, and I mean, I'm not talking from personal experience here, but I would say in the US where, you were using Premarin, I know there probably was there were deals and incentives to use that particular one. It might be something as like when it was being used in the women's health study, like perhaps the pharmaceutical company provided that as part of the study. So that just happened to be what was studied, and as these things go, unfortunately, there is often a business angle. It's just that that particular product then was being used by this network of doctors or network of clinics. So um, and we the literature was suggesting that altering that estradiol would not have any consequences, but then of course then that got revoked because of things like the women's health study. Not revoked, but then people were having a think about, okay, what other options do we have in terms of replacing the estrogen?
Okay. And for women watching who may be taking some kind of hormone replacement and they don't even know if it's bioidentical or not, could you maybe give some guidance about how they would be able to tell? And then really go into, well, assuming you believe it, of course, why a bioidentical version is better, like what the problem is with a non-bioidentical in your experience or based on what you've learned.
I would say the good news is that most of the estrogen that's being replaced now, at least in the UK, is a bioidentical estradiol gel, as well, as some of the patches. So it's not, so you can still get that now as part of the NHS. Um, there are still circulating non-bioidentical forms that often are, and I would say that applies to both estrogen and progesterone. I would say in the conventional medical world, it's still more of an issue with synthetic progestins. Like I tend to see that prescribed over and over again in the NHS. So rather than using progesterone, you're using progestin, norethistérone, others, and sometimes you'll see that as a combined package. So you'll have, let's say you will have the bioidentical estradiol, but then it will be combined with the synthetic progestin, which I would not recommend. But unfortunately, what will happen is if there's a stock shortage or something, then the bioidentical that is available won't be in stock, and so they'll be replaced with this what's considered an equal alternative, but it's not.
Right. Okay. And what's the problem with a synthetic version?
Well, a synthetic progestin will actually lower your body's production of progesterone, and it won't have the same effects on sleep and nervous system health. It will still, for example, in those cases where you're wanting to prevent fluctuations of these hormones, progestin can be useful to help with like dysfunctional bleeding and other things, but it's not going to have the effects of bioidentical progesterone on those other progesterone receptors in your body.
Okay. And so I'm thinking of the people who really defended the use of progesterone, like Dr. Michael Platt when he was on a while ago. And he talked about how a lot of the studies on the dangers of progesterone. So when he recommends progesterone, a lot of people go to Google, is it good to take progesterone? And then Google's like, oh, dangers, and it causes C word and all this kind of stuff. And he said all of that is kind of disinformation because it's true for the synthetic kind, but not for the natural bioidentical kind. Is that your view as well?
Yes, exactly. Because I would say that there is a stronger link between, at least from even looking at the Women's Health Initiative, there was a stronger link between breast cancer and synthetic progestin than there was even with the synthetic estrogen and breast cancer.
Yeah. Okay. Okay. Is there anything more you want to say about the conventional approach and maybe to warn people about or dangers or anything like that?
Just say that, I mean, it really does make me worried when, where there isn't monitoring because, and so what I find that I see in the conventional approach is, someone gets estradiol, progesterone, and then there really is no follow-up. They're just kind of told to come back if they feel it doesn't work for them. But I do think that, if you're, and I recognize that work where you look into like hormone metabolites and things, that's just not something that's going to be implemented into a conventional system anytime soon. Um, but so I think if you're not doing that, then you really need to be educating people about monitoring for things like breast lumps, monitoring for, um, I mean, even signs, yeah, that you could have excess estrogen, which might include, things like fibroids or, um, other kind of estrogenic growths, breast cysts, that could all be linked to excess estrogen. So it would be about kind of advocating for yourself and actually sometimes unfortunately having to say like, could it be from the excess estrogen? Could we like check the levels or could we do something? Yeah.
It just seems so unscientific. It's hilarious to me that anyone in my field is, dismissed as quackery or whatever by mainstream medicine because we're not scientific. And meanwhile, they're handing out all these powerful hormones and medications to people and not testing to see if it's too much. It's just the craziest thing in the world to me. It seems like the basics of what you should be doing. And you said it's like you think it's not possible. It's not that expensive or difficult to just test for like blood levels of estradiol, is it? For instance, is that, I know it's not foolproof, but wouldn't that be just a basic thing that you would do if you were prescribing someone estrogen?
Yeah, I would say that there is the problem with blood testing is that it's not the most accurate if you're on a topical estradiol, which is the type that's recommended as being the safest. And so generally, I have seen high estradiol levels in the blood in someone who was definitely over replacing their estradiol. So I think it would be enough to um, to warrant like if somebody is massively overdosing. But I would say that still you might have yeah, I would say I prefer looking in the saliva or even in the urine as a more accurate view of topical estrogen replacement, what dosing are is considered normal.
Which is more expensive, but of course it's only more expensive. Well, usually with lab tests, it's just economies of scale, right? It's only more expensive because not less people are doing it. If it became the new standard, it likely really wouldn't be very expensive anymore.
I mean, I think there's also there is still some truth that your estrogen levels do fluctuate based on when you last had the cream, and so conventional medicine just says, well, because the levels can fluctuate, there's no point checking it. But I would say like you're replacing that hormone every single day. So we would say that even if the levels fluctuate, you wouldn't go from very high to very low over the course of that day. It still would be worth doing.
Yeah.
Um,
There should just be a standard, right? Like with insulin or, well, let's say blood glucose, because that's tested all the time. There's a standard of you test it in the morning before you've eaten, and you're supposed to wait 12 hours since you last eaten, or whatever it is, right? So there could be a similar standard with estrogen, right? You test it in the morning before you take your estrogen, or after you take it, or whatever, right? There could just be a standard and a benchmark step.
exactly. Again, I don't recommend oral estrogen, but that is something that is being offered in the NHS. Like oral estradiol combined with like oral progesterone, that would be slightly more accurately represented in the blood. But you run the risk with topical estrogens that they're underrepresented in the blood and then slightly overrepresented in the urine and saliva. So you have to, the caveat is you typically have to pause the estradiol a bit before you do that test, which sometimes can have quite dramatic effects in females, but it's still the safest way to do it, in my opinion.
And why do you not recommend the oral version?
We have seen links between oral estrogens and conditions like DVT and blood clots, stroke, um, and to be honest, I haven't looked at the literature in as much detail for bioidentical versus the synthetic, but there was the link with the synthetic estrogens and clotting risk, and there is much less of a risk if you're using topical estrogens.
Okay. All right. Well, let's move on to optimal then. So what I've seen over and over again when women go to a bioidentical hormone doctor, menopause, postmenopause, they're given a bunch of estrogen, probably a milligram a day of testosterone, and then a small amount of like estrone, maybe, which is the weakest of the three estrogens, right? Now, I know it varies, but that's like the most typical thing that I see and that I hear of, which is a completely different focus, right? It's minimal amount of estrogen replacement, significant amount of the other two sex hormones. Um, so, what's your opinion on that? I just want to address that because even though that may or may not be what you do, that's what a lot of people are receiving who go to a bioidentical hormone doctor. What's your opinion on that? And what do you consider the best possible hormone replacement strategy? Of course, it varies per patient. You can talk about how you vary it depending on a bunch of stuff if you want, but maybe just like a classic presentation.
Sure, and just a quick slight correction. So there are three types of estrogen. Um, Estrone is actually the most potent estrogen. So
Oh, sorry, I meant
estriol,
estriol,
exactly. So you
right?
wouldn't want to replace
Thank you.
estrone. But what is an interesting point there is no one is really checking outside of, like I would say the more integrated sphere of like people's estrone levels. And if you're someone who converts a lot of that estradiol into estrone, that's a bad sign, and that you want to then work on lowering the estrone levels. Um, but I would say that your approach is actually that would be surprisingly holistic, that someone would actually even think about the estriol. I mean, again, I would say conventional doctors are becoming a bit more educated in hormone replacement, but traditionally they would they you know they a woman would have estradiol replaced. If they have a uterus, they would have progesterone replaced, and Nowadays, I think it's more or less the general standard I see is that they are put on a bioidentical oral progesterone, which I would say that even that is a decent strategy. Um, but still one you'd want to check. But generally, like being replaced with estradiol and progesterone is sort of as good as it gets from a from a conventional medical point of view. Yeah.
I think it's just the ratios that vary so much. Do you mind talking about ratios? Because as you say, a lot of the time they don't even base it on testing; they just give a standard amount. So could you talk about like the standard
I
amount?
mean, I would say that generally estradiols being replaced at around 75 0.75 milligrams per day topical, and often something between 50 to 75 uh, micrograms on a patch would be another option. Um, the oral estrogen, I am seeing that slightly more often now, which I personally wouldn't recommend, but generally, like I do see prescriptions for like 1 milligram of estradiol orally. Um, yeah, and
Okay. And how much progesterone in the mainstream world?
usually 100 milligrams is the standard. You can though get some, I would say some conventional doctors will sometimes go up to 200. And I would say from a patient advocate point of view, it's worth bringing that up with your doctor if you feel like, oh, actually 100, I felt better. Could I go up to 200? Especially if you're not sleeping well or if you've had a strong history of like estrogen dominant conditions, like if as a teenager or a younger person premenopause you were subject to fibroids, ovarian cysts, things that we do link with excess estrogen. That would be a sign that you would probably in menopause warrant more progesterone to counteract the effects of estrogen.
Hmm.
Yeah.
Interesting. And you talk about oral progesterone there,
Yeah,
right?
I
Mainly.
typically use oral progesterone because that has always had the best benefit from a nervous system mood point of view.
I think I might agree with that. Like Dr. Platt was quite strongly. I'm sorry, I keep bringing him up, but he's the other progesterone expert we've had on. And I think he was one of the pioneers. He was quite strongly in favour of progesterone as a cream rather than a oral because he said that with the oral, it's much more of it is converted to allopregnenolone. But I don't see that that's really a bad thing because that's like such a calming, right? Such a GABA agonizing hormone metabolite that just seems like it's beneficial. Unless the person is already too sedated, I guess, then you can make the argument to do the cream instead. But otherwise, I think it makes sense to me too.
Yeah, I would say like problem sleeping. I probably should have put that as one of the main symptoms, but that is actually a very common problem I see is frequent waking throughout the night as in people who've otherwise had very good sleep schedules and a good night's rest prior to this perimenopause menopause period.
If you've ever said something like, I've tried everything to lose weight and nothing works, then this message is for you. Hi, I'm Owen Robinson here from the Rejuvenate podcast. Most people think that difficulty losing weight is about willpower or calories or exercise, and the truth is it's not. It's usually one or more of 5 hormonal imbalances that are blocking you losing weight. That's why Dr. Miriam McKitsky and I created the Hormetics Weight Optimization System, a simple quiz that pinpoints your type, then matches you to the exact formula you need. Right now, we're launching the Leptin Balance Formula, and this is specifically formulated by Dr. Miriam and I, exactly for people who have this leptin resistance, which makes it very difficult for them to feel satiated by food. It's packed with African mango, Ceylon cinnamon, and alpha-lipoic acid. Ingredients shown in numerous scientific studies to help your brain finally hear the I'm full, I'm satiated signal so you can stop thinking about food. Go to advancedhealthgenetics.com/leptin, order now, and you'll be invited to join our clinical study the moment you check out. There's no cost for this, and you can track exactly how well it works for you, and you can get 20% off now by using code REJUVENATE at checkout. Go to advancedhealthgenetics.com/leptin and use code REJUVENATE for 20% off now. You deserve to feel satiated again. Okay. And the other thing I was kind of commenting on, it's funny the way you described it near the beginning of the episode, the mainstream approach is give them estrogen, and then, maybe some progesterone as well if they still have a womb. But actually, when we talk about the amounts, the person is receiving between 100 and 400 times as much progesterone as estrogen, right? You were saying, so it's interesting that, how obviously, importance is a relative factor, but it's interesting that it has a role that means that your body needs between 100 and 400 times as much, even from a conventional medical view these days.
Yes, exactly. And I will actually just also say, in response to, this idea that you want the least amount of estrogen, I would say that from a clinical perspective, we do see a lot of estrogen dominance nowadays. And so you have women who perhaps their whole lives, prior to menopause were actually used to having quite a bit of estrogen in their bodies. And so that dramatic decline in menopause is likely to affect them more. Uh, if we compare it to the baseline, you could argue that, okay, if in that estrogen dominant, premenopausal time period, they were suffering with things like cysts, fibroids, those could return if you then over replace the estrogen in menopause. But I would say that the benefits of estrogen, helping with brain clarity, bone density, um, they often do need to kind of to replace. And I've worked with some challenging cases where, using urine testing, I would say, okay, actually, I think your estrogen dose is too high. We need to lower. And it was a real struggle to get them to lower their estrogen doses because they automatically felt that their memory got worse, their energy levels got worse. So it is very nuanced. And I know it can be easy to say, oh, be on the lowest dose of estrogen, but I have to maybe kind of my feminist angle come out and say that, oh, a lot of these males are making these points and then they haven't seen the females sort of falling apart on very low estrogen doses. Yeah.
Well, speaking of males, you use the term there, estrogen dominance, which according to Wikipedia was actually created by Dr. Ray Peat. Um, he described estrogen as a stress hormone. Um, so I suppose you can make the argument that adrenaline also increases, mental clarity and even memory and all the rest of it. Would you agree with that characterization that it's a stress hormone, but you need a certain amount of it? I guess just like cortisol is a stress hormone, but you need a certain amount of it.
I mean, I would argue that estrogen has many mechanisms in the body, that aren't kind of related to that stress access, like for example, for bone health things. But I would say, like, when typically we use the term estrogen dominance as a negative, because we're seeing like certain estrogens from, peripheral conversion in excess adipose tissue. So, as we see, um, people becoming more and more overweight, we are seeing kind of a negative, estrogen dominance that we don't want. But I think there is, if we were to take kind of the obesity argument out, I would say there were still women who, have just always had higher levels of estrogens, and then I've been prone to those conditions, associated with estrogen dominance. And I wouldn't say that it's always that I can link it back to their lifestyle. I think their genetics also plays a big role there.
Definitely, yeah, and we see that in the reports. Some people just have a tendency to, in advanced health genetics, some people just have a tendency to have high levels of estrogen, and it's just the way they were born. And you see it also anecdotally in families, right? Estrogen dominance is, in fact, that's one of the questions you ask, and it's in our hormetics quiz to assess estrogen dominance, is do you have a family history of, the symptoms of it?
Even from
Because
a
there's a definite
body,
genetic
yeah, I was gonna
component.
say, even from a body composition point of view, you'll often hear that from women that, like, my females in my family, we've always accumulated weight on the lower half, which tends to be associated more with an estrogen dominance.
Yep, 100%. Okay, yeah, that's good points. Well, so am I hearing that, as far as you're concerned, the other than making sure you use bioidentical hormones, there really isn't that big a gap anymore between the mainstream medical approach and what you would do as a functional medicine doctor who's focused more on optimization? Would you use similar levels of progesterone and what about the argument of estradiol versus the weaker estriol as being safer? Yeah, let's start with that.
It's a good point, and I would say, because I think as a, a private functional medicine doctor, you're always kind of getting criticism from the conventional sphere that you're offering something that isn't needed and is expensive. And so I always make that argument that actually you can, I think still the NHS approach where they are getting estradiol and progesterone is better than nothing. And sometimes it actually works very well for a cohort, certain cohorts of women. Um,
Yeah, I can see if it's the bioidentical form, especially, that it would be a lot better than
uh,
nothing. Yeah.
but I would say where I think it can be useful to see someone a bit more holistic is that they kind of tend to ignore the other hormones. So, for example, testosterone is not like that we can't prescribe it on the NHS for women, even if the testosterone is low on the blood test. Minus, I think nowadays there are some very specialist clinics that take you years to get into where they might, on a case by case basis, agree to it, but by and large, like women cannot really get the testosterone replaced. And I would argue that that is a very important hormone to also look into optimizing. And the same goes for, other like adrenal hormones like DHEA, or in some cases also pregnenolone, um, and the other estrogen, estriol. I will say you can actually get a bioidentical estriol gel on the NHS, but it's usually um, a separate gel or cream that you're using only vaginally. Um, you know, but I would say that there is a benefit of just having the estradiol and the estriol together on a cream that you use topically, as well as potentially also replacing it vaginally, because it is a very low potency estrogen that um, you can actually, you don't have to be as, not that you don't have to be as careful in the dosing, but it's not quite as nuanced as like prescribing the estradiol.
Yeah, and we forgot about that. I guess that's another symptom, right? Is vaginal dryness. That's one of the other reasons that estrogen is given, so women can carry on having sex, basically.
But I would say, like, I think for vaginal dryness in particular, estriol is a much better option than vaginal estradiol because it's much less risky and it's actually the estrogen that's most important for your mucosal tissue. But I still see this over and over again that women are being prescribed vaginal estradiol, which then further adds to the more estrogenic load.
And the potential unwanted growths element in that area. Yeah, 100%. Okay. So you talked about testosterone, DHEA, and pregnenolone. I think even the comments, like I remember some woman recently was like, I'm taking progesterone. Should I have pregnenolone instead, and all this kind of thing. I think there's some confusion among women. So as I said, what I see, the most common thing I see, I'm not saying it's right, but the most common thing I see is uh, high amounts of progesterone, often like 150 milligrams a day of the topical, 1 milligrams a day of testosterone, and I think half a milligram of or 1 milligram of the estriol. So I'm not saying that's right, but as I say, that seems to be standard among alternative health practitioners. So what would you say is more generally, obviously things are case by case, like an optimal stack, to use the biohacker term, protocol that you would put together for a woman? Let's say, well, actually, let's do one at a time. Let's do perimenopause, then let's do menopause, and then postmenopause.
I mean, I would say perimenopause. Um, It's a tough one because I have to say that I do see many cases of perimenopause where women's estrogen levels are still high, which is why I'm not so quick to just put them on estrogen without checking. But I do frequently see low progesterone in that cohort, and I often have to then really, like write to a person's GP to explain why I'm doing this because they will say, well, you shouldn't be replacing progesterone without replacing estrogen. It's like, well, actually, but if this person already has normal high estrogen and low progesterone, we're actually just getting things more into balance. So I would say that, it's a classic case, particularly in the early perimenopause years, would be you're just replacing progesterone, testosterone, and DHEA. Um, Somewhere along the lines of often say 1 milligram of testosterone, 200 milligrams of progesterone, um, and somewhere along the lines of like 10 to 15 milligrams of DHEA as a starting dose. Um, yeah.
And I think we've explained progesterone, testosterone. We haven't really explained that much, although people probably already have heard of it. But DHEA, probably most people don't really remember what that does. So could you explain? Let's do testosterone and DHEA. Why are we adding those two?
Yeah. So, I mean, I would say that the kind of symptoms I tend to see in these perimenopausal women, uh, poor stress resilience, feeling like they're not really coping with the demands of life, low energy, is often an adrenal issue, maybe even more of an adrenal issue than it might be a sex hormone issue. And so I will typically see. So just to give you, just to kind of recap, DHEA is a hormone released by the adrenal glands. And remember, cortisol, your stress hormone, is also released by the adrenal glands. So it almost acts as a counterbalancing mechanism to cortisol, where it's more of it helps to, for example, like decrease your cortisol appropriately after you've had a sudden rise of cortisol. It also has properties of helping with immune balance. So, for example, we see links between low DHEA and autoimmune conditions. Um, and also DHEA is very important for brain and cognitive function. So we often will see low DHEA in those that are struggling with memory loss, brain fog.
Okay, fantastic. I'm not sure if you said this, but with testosterone, I think assertiveness is one of the things I've heard from women. Like they find it easier to be assertive, which both men and women can struggle with, but especially women often through cultural indoctrination, all the rest of it, and it just helps them to stand up for themselves and stuff like that.
But that, and I would also say from just even a physical strength point of view, a lot of women who think, oh, actually, I'm losing muscle mass or I don't feel as strong when I'm lifting weights, it can be really very helpful. Um, I will add though, just because I don't want to completely discount estrogen, I do see a lot of women as well who have low estradiol levels in the perimenopause, and we can see that there was likely a significant drop. Um, but because that kind of estrogen production isn't so low yet, the kind of more, I would say, alternative integrative approach would be to replace the estradiol and estriol at more of like a 50-50 percentage. And then the older you get, typically you replace more with estradiol because we think that is more linked to bone health, brain health, and some of these, some of the complaints of like osteopenia and things we would expect to get worse, and women would need more support as they get older.
Okay, all right, awesome. Okay, I think that all makes sense. Let's go to menopause. So, what's the optimal strategy once a woman's fully in menopause?
So the optimal strategy, I would say, first of all, is a lot of these tests that look at your hormone metabolites, I usually don't do if we see that the hormone levels are close to zero in the blood. Um, so so there you do, I mean, so because if you've not started any hormone replacement, bloods will actually be an accurate measure of your endogenous hormone production. So what I'll often do is if we see that a woman is depleted in all the hormones, which typically after the 2 years of no periods, we tend to see that. Not always though, I will still sometimes see like reasonably good levels of estrogen and very low levels of all the others. But as a typical example, I'd say you're then replacing more of the estradiol. So I usually have something like, let's say 1.5 milligrams of estradiol and perhaps something like 75 750 like 0.75 milligrams of estriol. So the ratio would be more estradiol to estriol. Um,
So that's higher than you were saying earlier. Is that like in the mainstream approach? Are you giving more than the mainstream approach because it's better, or is it because when we're talking about mainstream approach, we're talking about a different part of the menopausal journey?
I would say that the mainstream approach, when I said like one pump is about 0.75, most of the time I see the conventional approach being even like 3 pumps a day. So often they're going well above that 0.75. Yeah,
Okay,
but
so the
yeah,
average is more like 2 milligrams in the
so somewhere
mainstream
around
approach.
there is what I typically see. And I mean, obviously would take a more careful history. So if I was worried that somebody seemed to have a lot, had a history of fibroids, I probably wouldn't start at that dose. I probably would start at something like even 0.75, or I would maybe approach it with being like half estriol, estradiol. So they would have maybe 0.75 estradiol, 0.75 estriol. Um,
Okay, so those amounts you gave before are like minimums for
yeah.
estrogen. Got
It's
it.
it's
Okay.
tough. I know, like hormones are quite complex. So I know it sounds like, oh, actually, no, it could be this, or they're taking too much. But it really, you do have to do it on a case by case basis. Yeah.
Yes. No, you're giving ranges. No, I got it. I got it. This is like a range. Okay, so I misspoke before the ratio of progesterone to estrogen, but it's still like 100 to 1, roughly. Okay. Okay, sorry. Yeah, I'm with you. So that's estrogen. What about the
The rest,
rest?
to be honest, doesn't change that much. I still generally would be starting at 1 to 200 milligrams of progesterone, and usually I still would start with 1 milligram of testosterone. But I do like I'm testosterone is sort of the one hormone that I'm not so worried about increasing the dose of in women, like apart from acne, facial hair, which is what I tell women to watch out for. If your levels come back high, it's not necessarily, yeah, it's not as dangerous as I would be worried about if someone's estrogen levels were very high. So I will, you know, increase to 2 milligrams, sometimes 3 milligrams, in women, particularly ones that are quite frail.
Mm. Okay. Interesting. And that can help with putting on muscle mass, as you said, which is very important for women, obviously everyone, but including women as you get older to prevent accidents, well, breaks, all the rest of it, right? Falls. There's this thing about if you have a fall, once you're past a certain age, you're unlikely to ever recover, right? Like, and that's due to.
Biggest mortality risk, actually, like within the next year or two. Uh, and I mean, that actually brings, we haven't really touched on this, but one of the areas that I've trained in under has been it's been cognitive decline and Alzheimer's. So I certified with the RECODE, in the RECODE protocol, which is the work of Dr. Dale Bredesen, and using a more holistic approach to cognitive decline. And hormones are a big part of that. And this is where I would say that the more integrative approach differs widely from the conventional approach, because the conventional approach, the idea is they will replace hormones for a period of time, usually kind of no more than 6 or 7 years, and seeing it as a bridge between like preventing that sudden decline, but then ultimately getting women off of hormone replacement. Um, but the looking at it from a cognitive decline, a brain health point of view, there's, Bredesen's approach is actually considering even replacing some of those hormones bioidentically, in an older person struggling with cognitive decline.
Yeah. Okay. Well, that leads us nicely into what was going to be the next section, which is postmenopause. But I'm glad you brought that up. So, with the conventional mainstream medicine approach, um, those hormones, the production declines, so you replace them, and then it doesn't come back. So, why would you stop replacing them?
Question, and I don't. I think we're kind of then towing the line of, if we look at kind of a natural life cycle, eventually your hormones drop to zero and you start approaching the final years of your life. So whereas I guess you could argue that replace.
So, is it just like accepting the obsolescence of the organism? Is it like, but then why? You could okay. Well, actually, I was going to bring this up earlier, so I'm glad we brought it up now. How do you reply to people? And then, sorry, we'll go back to the point, but I think this is a good one. how do you reply to people who say, I don't want to take any hormones, even the bioidentical ones? It's not natural. If my body wants to start making less hormones, then it's fine. And I guess you're a doctor, so you'd probably say fair enough. But let's say it was, I don't know, a parent or a loved one making that argument to you, not so you're not in the role of a doctor. Um, how would you reply to them if they said, it's not natural to be replacing these hormones?
It's a really good point and question, and not an easy one to answer because some women actually sail through menopause without many symptoms and then seem to do okay with that drop in hormones um and generally
Why is that, you think?
most women again, because some of those symptoms of menopause, like the vasomotor symptoms, are also linked to adrenaline and adrenal health. A lot of those women I found have always been have been taking care of their adrenals. I mean, I have a client who's been a yoga instructor for 30 years and has always lived quite cleanly in terms of diet, stress reduction, and she commented to me that actually I never felt the need because I didn't really feel much different with the drop in hormones. So you could argue that for some people it works. I would say that but for the majority of people, I would say that they would likely notice some decline, but perhaps they don't necessarily need to be as mentally sharp as before. I think nowadays we're also seeing um, women who are working into their 70s and 80s from just personal experience. A lot of the lecturers that I see and the conferences I attend are women in their 80s and they are still taking hormone replacement and are actually advocates for keeping it there. But you could argue that for some people in their 80s that's kind of more of a relaxed time period in their life where if they can't remember why they walked into the kitchen, they're just like, okay, the thought will come at some point. Um, that's my viewpoint, but
Well, no, I think I kind of interpreting that honestly in my view as like accepting obsolescence, like what you just said. Maybe my mind doesn't have to be sharp anymore. Like I'm retired. That kind of thing. But the thing you said about stress, I was like, but aren't these hormones, whether it's DHEA or progesterone, anti-stress? And I was just thinking about my own personal experience. And I used to work in a retirement home, and it was a retirement home, it wasn't a care home. I think the average age was late 80s. And these are people who are still, not needing full-time care. They were still independent, even though they were living in this retirement community. And so you'd really say these are like, very successful, healthy people to have survived that long, and still be able to look after themselves and not need full-time care. But one thing I noticed about them is they all had a very high level of fearfulness. This just seems like I'm not saying it's not possible to transcend, but I would say it seems to me like a standard part of aging is that you become more and more fearful, you become more and more rigid, you become more and more um, wary of the unknown, whether it's unknown ideas, unknown people, unknown environments, unknown situations. And to me, when I learned about all this, it made sense because it's like, well, the men are lower in testosterone and therefore DHT, the women are lower in progesterone and therefore pregnenolone, and they just don't have the same, resilience to stress anymore. They're just going to be more easily stressed and more anxious. Um, so it's interesting to hear you saying like that just take more hormones to relax. I think you were talking about more relaxed in the sense of not needing to be in peak performance anymore. But I also don't think that they're really relaxed as they get older if they're not on hormone replacement. They seem to be more and more anxious from my experience.
definitely, and I mean, I would say that I am an advocate for hormone replacement later in life and not necessarily stopping. The testosterone example is a really good one because, I've also seen studies about how important testosterone is for cardiac health, as well as for it, obviously, kind of the ones we think about more like avoiding sarcopenia, also for cognitive health and kind of more, I would say that like decisiveness factor. And a lot of the doctors that I listen to or follow, like they give personal experiences that they advocate that their elderly fathers take testosterone, and it isn't just a sexual health kind of hormone, which is I think what the mainstream likes to portray it as, but that it's also a holistic hormone that can help in many other ways. So I mean, I try not to push it, but I would say that
Well, this is why I
yeah.
said, I know as a doctor you can't push it, but this is why I said, if it's a loved one who you really care, just that they had the best possible quality of life, that's what I was, to go back to that question, what would you say to answer this issue if it's not
Yeah,
natural?
and I would also say, because we didn't really touch upon this, but there is, there's also, what happens to women who go into perimenopause very early. So, we call that premature menopause, or primary ovarian insufficiency. So we do see women who go into menopause in their 30s. I would say the 40s. I would say the early 40s is still very early, but it's not kind of considered pathological, whereas like in the 30s it would be. And with those women, I've often seen that they might have a history of, um, perhaps like too little calories, or perhaps histories of eating disorders where maybe there has been a suppression of their hormones overall. I and a lot of them are actually quite resistant to replacing those hormones and really want to look for natural approaches. And there are plants and herbs that can help stimulate the receptors, but they're usually not going to be able to replace the level if your level is close to zero and you're wanting to get to a physiological normal. So I would say that you really have to look at how far out of range that person is. And if it's a woman in perimenopause who, let's say, is in their 50s, and um, and the decline isn't so bad, they might actually do well on something like Siberian rhubarb for hot flushes, or a black cohosh. But I haven't found that it's enough to move the needle significantly to actually get the levels to, to more of a premenopausal level.
So I tried to do the maths recently. Between 2008 and 2022, I easily spent over $100,000 on supplements that ultimately did nothing for me, because nobody told me my genetics made me desperately need some nutrients like tyrosine, lysine, and vitamin K2, while making me also really struggle to break down some chemicals like histamine and aldehydes. I was just throwing money at balls while staying chronically unhealthy. Advanced Health Genetics All Access would have saved me literally decades of trial and error and well over $100,000. Here's how it works. If you have one, you upload your existing raw DNA file from companies like 23andMe, Ancestry.com, MyHeritage, if you've ever done any of those. And within hours, you get over 500 reports that spell out exactly which vitamins, minerals, amino acids, and essential fats you're genetically wired to run out of first. Things like vitamin B12, zinc, magnesium, EPA, DHA, folate, iron, basically all of them. You'll find out which foods secretly wreck you. Maybe saturated fats, maybe it's carbs, maybe it's oxalates or salicylates, maybe salt. You'll get your personal inflammation score, insulin resistance score, visceral fat tendency, artery hardening risk. You'll get hormone and neurotransmitter weak spots, whether it's testosterone conversion, cortisol clearance, dopamine synthesis, estrogen issues. And you'll get fitness DNA reports, like, are you built for marathons or sprints? Do your tendons tear easily? Do you have a tendency to quick or slow recovery? And every recommendation in all those reports is scored from 1 to 5 for impact and evidence. So it's really clear to you the 5 things that you can do to fix this month, instead of like 100 things to overwhelm you, which may be a tendency if you listen to a lot of different podcasts with a lot of different conflicting advice. Plus, you get every new report we add for life for free. And yes, we're fully GDPR compliant. We anonymize your data. We store it separately from your name and let you delete everything in one click if you want to. Don't make the same $100,000 mistake I did. How do you get started? Go to advancedhealthgenetics.com, and if you have an old DNA file, upload it and you have your first reports in hours. If you don't, select the DNA kit option and we'll send you a DNA kit where you just do a really simple saliva collection and send it back. Advanced Health Genetics is already by far the most affordable DNA reporting company of its kind. But if you use the code REJUVENATE at checkout, you get an additional 20% off your order. Click the link in the description or pinned comment right now. Your DNA is waiting to tell you exactly what it needs. Let's listen. Well, I don't think I'm going to get an answer from you about how you would persuade someone it's a good idea, probably because you're not allowed. So just to put it in this episode, I'll very quickly give my answer to that question then. So when people say to me, I don't want to take hormones, even bioidentical, because they're not natural, my answer would be, nothing about your lifestyle is natural. It's not natural to have food available all the time. It's not natural to have electric light of any kind, especially at night. It's not natural to be so protected from, the elements like the cold or the heat. There's very little it's not natural to be surrounding by, EMF frequencies. It's not natural to have all these man-made novel chemicals in your food. Nothing is natural about our environment. That's the first thing. The second thing I would say is it's not natural to have a sharp mind at the age of 80. It's not natural to be to have a strong resilience to stress and to be, curious and inquisitive at the age of 80. It's not natural to have high energy at the age of 80. It's not natural to have a strong sex drive at the age of 80. It's not natural to what else can I say? It's not natural to have, strong physique at the age of 80. Like, none of these things are natural. It's not natural to, be ambitious, all of these things. And so, yeah, this is Dr. Miriam's point. It's like, if you want to kind of go along with the cycles of nature and kind of just decline as you get older, fair enough. But, I think our culture is generally against that, in the same way that we're against, letting ourselves freeze because it's winter. We kind of fight against nature by creating um, shelters and heating systems and all the rest of it. And so, in the same way that we don't just give in to winter, we also just don't just give in to aging, generally. And and as you say, a lot of people are doing stuff anyway. It's not really natural to use stimulants to get through the day, in my view. It's not natural to take an antidepressant because you're unhappy. Like, none of this stuff is natural. But the I would say one of the most closest to nature thing is to just get your hormones, the natural bioidentical forms that your body makes anyway, closer to a level that they were at when you were at an age where you felt your best. And so it's more natural to me than most things that most people already do. So that's my answer. Back to Dr. Miriam.
Yeah, I completely agree with you. And that's good that you brought up that point, because I make that point quite a lot when it comes to energy and, for example, like thyroid health and adrenal health, that, people will say that, like, particularly in the winter time, people seem to struggle more with energy. And, I always kind of make that comparison. Look at mammals, like animals that hibernate, even look at your pets, like they are often lower in energy in the wintertime. They're sleeping longer. That is kind of, from an evolutionary perspective, how we were supposed to be, but the modern world doesn't really allow it. And so you are kind of at odds trying to fight that to keep your job, to try and, like, be innovative. And so, yeah, you do have to, like, you're in a way trying to play with nature a bit, but you're doing that in the way that you're at least trying to replace what you would have been producing naturally. And then also the constant, bombardment that of, like, let's say, screens, and having to be kind of on the whole time, that does affect your adrenal access. And we do have that phenomenon of cortisol steal, where if a lot of your hormone production is going into cortisol, and that access, it does affect your hormone production down the line. So you might be more predisposed to lower sex hormone levels because you've had periods of your life where just so much of the hormone production went into cortisol. So
Yeah, let's explain the cortisol steal a little bit more. And then also, in your protocol so far, you haven't mentioned that you generally give pregnenolone. So could you explain both of those and go into pregnenolone a little bit?
So just the issue of both, I would say, cortisol and pregnenolone steal comes from the idea that, all of your hormones are produced from cholesterol, and that's actually one of the reasons why you don't want to drive your cholesterol too low, because you then are eliminating that building block. But the idea is that if I would say, for cortisol as also a life-saving hormone. You need that stress hormone. And pregnenolone, because of its effects of a precursor hormone, but we know that pregnenolone does also have a role in brain health. So you could argue that if your body needs more of that, there's going to be a lot of that cortisol is going to be a lot of the cholesterol is going to be converted into cortisol, into pregnenolone, and it's going to be used up. So there isn't as much of there's just not really the building blocks to then convert that down further into DHEA, testosterone, estrogen. And so we call it steal that, it's kind of stealing the resources, and you're left with a lower level of the other hormones.
Yep. And I think the best thing to raise pregnenolone, in my understanding, is probably T3. It's thyroid hormone because it supports the conversion of cholesterol to pregnenolone. And we've talked about thyroid in a different episode and maybe several episodes, so I don't want to go into that here. But other than that, in what cases would you recommend pregnenolone to someone?
Yeah, I mean, I would say I was taught to actually not use it so often because, we because it is a precursor hormone, we would expect that if you're somebody who's estrogen dominant, you would likely then use the extra pregnenolone to try to convert that into estradiol. It wouldn't go into where you might actually need it. So I used to not really recommend it very much, but I have had cases over the years where um, someone came to me already on pregnenolone, and then when I tried to reduce it, or stop it, it really seemed to affect people cognitively. So I do use it occasionally when brain fog, cognitive decline is the main symptom. But I'm also, and let's say their T3 levels look absolutely fine, and I don't think it's strictly a thyroid issue.
Could it ever be helpful if someone's cortisol is actually low to give them the building block to make the cortisol?
Yeah, no, it does. It definitely would. And so I will sometimes prescribe both DHEA and pregnenolone from that perspective. And I haven't, I mean, I have then tracked, and I haven't actually seen in practice it really happen that I drive up someone's estrogen too high, and I think it was just because of the pregnenolone. So it's one of those cases where like you're taught something, and then you test against it, and you're sort of using more your clinical judgment.
Which is probably not true for DHEA, right? You can overdo DHEA and you will see estradiol going up.
You see both estradiol and sometimes testosterone as well. So you will like that the things to watch out for with excess testosterone. I also find the same with DHEA. You will sometimes get facial hair and acne, and that might be a sign that there is too much conversion into testosterone.
Okay. Well, this is fantastic. I think you've answered all my questions. So if someone would like your help with this specifically, they can find you at health, Miro, .com. Is there anything else you would like to shout out, Dr. Miriam, where people can learn more or find out about working with you?
I'd say, as you said, we're feel free to look me up on Health Miro. We're also on Instagram too, and we do try to have some content there, just talking about what we do. I work with a nutritionist, Elena, so I would say if optimally looking at your hormone replacement, you do want to be considering the role of the gut and the gut microbiome, xenoestrogens from the environment, your stress. So you really, I would say the best approach is to have a more multi-disciplinary team looking at that. Because and so that's why you just want to have those levels optimized, which is why we work the way we work, where we really try to make sure that, when we're replacing the hormones, we haven't ignored those aspects of people's lifestyles. And it's a tough one because I would say, people who are really struggling, they don't want to wait 6 months to optimize their gut or to eliminate toxins. But I would say that you can do it simultaneously, at least, be working on detoxification, be working on the gut microbiome whilst you're getting the hormones replaced. Yeah.
I think that's the best approach. Yeah, absolutely. Because I know we have a lot of people on and, are kind of Puritan about this. You have to do it by detoxing or you have to do it by whatever. And in the meantime, when you ask them how long it takes, they're like, it could be years, often, if they're being honest. And it's like, well, that's fine. But even if you're right and your method works, a lot of people won't stick to it if it means having to suffer for years. So it's, and on the other hand, as you say, going to a bioidentical doctor, a hormone doctor, only having them prescribe hormones, and then nothing else, and not addressing as to why you may be, more out of balance. Maybe because a lot of the time it's not only aging, right? There's other reasons that have thrown you out of balance, perhaps prematurely, and to not address any of those root causes is a really bad idea, because even if you kind of make yourself feel better by replacing the hormones, you may actually develop more serious problems from those things being unaddressed and ignored. So doing both is absolutely the right thing to do. And, it's one of the reasons I feel good about recommending you. One of the reasons I like to have you on as well, Dr. Miriam, is in the comment section, I do get a lot of, I talk about hormones and stuff as well, right, and various things like this. And I get comments like, what should I do in my specific case? And I be like, well, you've got to see your doctor about it. And they're like, full well that no doctor understands any of this and no doctor's going to help. So I like having you on as an example, as someone who totally understands all this, totally, is able to help, is actively seeing clients. It's great that I think today, more than any other time, we've talked about your experience in the mainstream medical field, where you're also seeing a lot of patients and how you're helping them, and how in this case, actually, these days, it's not even that radically different from your private practice, which is interesting. I don't know if the UK is actually better now in this regard than the US. It'd be unusual if the UK was ahead of the US when it comes to...
I would say it's interesting you pointed out, because actually, bioidentical progesterone, unfortunately, is a lot cheaper in the UK than it is in the US. So I've had American clients who have told me that actually, it's they actually would prefer to travel to the UK to get it than go to a US based practitioner because of the cost. But so I do think that maybe might be one area where there's one sort of one thing we might be slightly ahead with. But I would say, like, my approach is obviously not, it's not unique to me, in the sense that for people who are looking for doctors more local to them, I think the type of hormone education that is promoted by the Institute of Functional Medicine, or A4M, so the American Academy of Anti-Aging, all the practitioners, I think, would more or less have a similar approach, and definitely more looking at things from a root cause perspective. So either of those places would also be a great place to find someone who's might be more local to you, or who would be able to prescribe a bit more easily.
Fantastic. Well, that was brilliant. That was an excellent education. If you have any comments, go to YouTube, or questions, go to YouTube, put it in the comments. It may well form the basis of a future episode of Dr. Miriam. Or, of course, you could just go directly to her, but I don't know if she's answering comments on social media, but you can go to her and have an actual consultation. I think they do a discovery call where you don't pay anything, and they see if you're a good fit for their specific practice. So is that still correct, Dr. Miriam?
So we do offer free 20-minute discovery calls, and we do have a kind of a hormone-based program where we are kind of addressing, looking a little bit into those root causes. But yeah, I'd be more than happy to discuss your individual case, and likewise, Elwyn, if there's any areas of this. I mean, unfortunately, hormones are a huge topic, so I'm sure, like, there are certain aspects we could go into in more detail, even, like, more anomaly cases, what happens, like, if you do have a cancer history, or and I'd like, what can you do to then optimize things. Would be more than happy to share kind of my experience there, so just let me know.
Thank you. And I think the next episode we'll go into is probably that you suggested before we recorded, which is the male version, the andropause, because that's, more recently been realized, right? It's not as sudden and maybe not as dramatic as with women, but men go for their own hormonal decline, which is also not good. So we'll address that in a future episode. Let us know if you'd like to see that, and we'll move it up in the queue. For now, thank you so much, Dr. Miriam, and I'll see you next time. Hey, thanks for watching the video. If you enjoyed that, I recommend watching our latest episode, which you can do by clicking above, and make sure to subscribe, like the video, comment, and share with anyone who you think might appreciate it. Thank you.